It's been great to be here today, yesterday, and as you've heard before, at the day we spent funded by the Liberty Fund, having discussions with Alessandra and all of the other groups, and to have conversations on the margins here today as well. So it's now our turn. As you've heard, I'm Rich Scott. I'm the Chief Medical Officer at Genomics England, and I'm joined by Alice Tuff Lacey, who is the program lead for our newborn genomes program. What we're going to do is tell you a bit about the program, but we wanted to sort of frame it again in how we, Genomics England, operate. You'll know from what I mentioned in the panel before that we are a UK government-owned company, so we're owned by our Department of Health and Social Care. That's the same department in the government that funds our National Health Service. And I think our existence, and for us, the existence and our deep partnership with the National Health Service is crucial to the way we approach the sorts of programs we run and the way we work in our health system. And Alice and I have both been at Genomics England the last 7 years, so not quite since its inception, but through, if you like, the first partnership we had with the NHS, which was the 100,000 Genomes Project, which was we refer to it as an NHS, so a health service embedded translational research program. And really there, our question, responding to changes in sort of the availability of technology and the data and analytics science, and what we could see was potential, was exploring the value of whole genome sequencing in a diagnostic context. And we've learned lots through that, lots that has, because we worked closely with the NHS as we delivered that program, we learned not just about the science, but also about the sort of gritty reality of what is hard to deliver. So just to give you a flavor, in our cancer program, one of the most important lessons was about the reality of getting samples that were high enough quality for us to use for whole genome sequencing. And it was about knowing that, for example, it's all very well in, academic center A to do this. They were all nicely set up. They had research staff on hold. They had, the right facilities. In District General Hospital B, sometimes the problem would be we didn't have a fridge to put your, or a freezer to put your fresh frozen sample in, and there wasn't space to move it, etc. And it's often those things which are most crucial and remain for us in terms of delivering just diagnostic support for the NHS that remain most crucial. And so as we think about our newborn genomes program, which we're very lucky to have had funded by our government to address these big questions, what's been crucial as we've been designing it is to do that with the NHS and with the people who would be both partnering with us to do this, to deliver this program, to explore the potential and the potential downsides also of carrying out whole genome sequencing or offering it to all newborns. But also because they'll be the same people that, if this is adopted, who would be delivering it then. And so learning all of those horrible lessons through that process is just as important as thinking about some of the sort of more obviously scientific questions that people immediately obviously jump to. So we've been designing our program. We've been sort of a program funded by the government the last 18 months, although we've been working on the program sort of for several years before in terms of thinking about the potential and understanding what the potential value and the best ways of approaching it might be. And a lot of that time has been forming networks and advisory panels with partners, particularly in the NHS, but also elsewhere. So, for example, we have established an NHS steering group, which is chaired by one of the chief executives of a big women and children's hospital in Birmingham. She's also someone who chairs some of the central NHS England decision-making bodies on maternal and child health. On that panel, we have representatives from our College of Midwives, the Royal College of Paediatrics and Child Health, et cetera, et cetera. And so really making sure that we go on this journey together with these people is absolutely crucial. And one of the things we spent some time on during the first year of the program was really actually jointly setting out what the vision, what the questions are here. What's really clear is that people are excited about the potential. What's also clear is that people are really anxious about the reality of delivering this, about some of the potential downsides in the context of a busy health service. What does this mean? How long will people have to have conversations with families about potential recruitment to the program, or if this were rolled out, offering this as a service? And so really sort of going on this journey together is crucial. We can see that there are a number of different potential areas here for benefit, and we've just felt in our program it's really important to call those out as separate. So in our program, which we're running as a ethics or research ethics approved study, will be embedded in the NHS, we are calling out 3 areas of sort of separate investigation. They obviously overlap, but we also think it's important to call them out as separate. And as we do this, and towards the end of the talk, when I come back on after Alice has talked for a bit, I'll talk to you a bit about the evaluation we're doing. But I think the way we perceive these different areas of benefits, they're also areas of benefit that will be decided on potentially separately. This isn't you use whole genome sequencing and therefore all of these things become definitely the thing to do. And we think it's useful to call out that there's a question around the potential for whole genome sequencing to sit alongside the current approaches to newborn screening. You've heard David Bick, who we're very lucky to have joined us from the US, talking about how we're thinking about this. But I think that's sort of really, really key. And I guess we're thinking about that from a conservative standpoint, starting with a sort of a cautious approach here so that we can learn and go. The second aim is around research. And that's research primarily to help us learn about what screening might look like tomorrow. We know new genes will emerge. We know different prioritization approaches will emerge, but also we'll be taking consent for participants to have research done more broadly around healthcare questions. So, for example, really crucial to both the success of this program, but also, for example, diagnostics using whole genome sequencing, is really understanding the allelic architecture of the children born today in the UK, who are much more diverse than the communities who we have represented in, even, for example, UK Biobank, who come from a different generation. And we really need to sort of make sure that is addressed. And then thirdly, the potential for the genome data to start to be an asset that, if stored, could be used more than once in a lifetime to answer different questions. For example, if a kid gets sick, age 5 or 6, nothing was picked up on an initial screen, and we wanted to sort of go back and use that genome to ask a diagnostic question across a broader range of conditions. That seems like a good use, but are people happy us continuing to store that data? Is that right? Is it better simply to go back and resequence? So a little bit about the numbers before Alice dives into some of the details. We're still very much in design phase. We're expecting to launch the study next year. And we're wanting to make sure our recruitment is broadly across a wide range of footprint in the National Health Service hospitals, not just academic centres, but also community settings and so forth, and be really representative, as I say, of the diversity of the children born in the UK today. We're looking at principally at the sort of health economic outcomes and sort of calculations of clinical utility and so forth. And the power calculations that we've done suggest that we need to be looking at quite a large number of children. We're very lucky to have been funded to sequence 100,000 babies, which we think may well be enough. We know that we'll learn more as we get closer and closer to reality, but we think this is something that's important to do at scale, to answer well. We're also enormously fortunate to have had the funding to do that. So I'm going to hand over to Alice to tell you more about the programme, and then I'll close by telling you a bit about how we're going to evaluate it.
Thanks, Rich. So when we started out, we wanted to put together some core principles about how we worked as a programme. And I think a lot of these have been touched on today about how important some of these principles are. So the first one really is this point around co-developing. Because we are very much working in partnership with the NHS, we really need to work closely with the people within that, both the professionals that work within that system, but also with parents and patients. And that's a really important part of how we work as a team. What that means in reality is we have a policy in our team. We actually say that we'll talk to anyone. We'll never say no to a conversation. And I think what's really important in that as well is making sure we're talking to the people who are critical of the programme as much as those who support what we're doing, because actually they're the ones who push our thinking and help us make sure we're achieving the best quality that we can. Transparency as well is a really core principle of what we're doing. We know that programs like this will live and die by the people who choose to participate in them. And we know also there's some really complex decisions that we have to make as a program, and not everyone's going to like some of the decisions and approaches we take. And so transparency is a really important part of that, and being able to articulate why we make the decisions we have. And that kind of leads on to the next point around making sure we as evidence-based as possible in some of the decisions we're making. We spent quite a lot of time building up to this programme, trying to really understand the landscape and do quite a lot of preparatory work, both in terms of some work understanding parents' views, which I'll come on to in a minute, but also feasibility pieces of work to make sure that we can actually try and make those decisions as much as possible with evidence at the heart of it. Finally, flexibility. So we know that, programs like this are innovative. Even developing a conditions list is going to evolve. Our approaches will evolve. And so actually flexibility is a really important part of developing programs like this and building in the capacity for that flexibility. I'm going to try and press on. Yay, I did it right. So as I said, public participant and ethics engagement has been a really important part of this programme. And I think that's partly a reflection of the fact that we are a national programme, we are government funded. So we need to make sure we are thinking and embracing a lot of the big ethical challenges and doing the right level of engagement with people to understand what they think about these things. What we've done is split this sort of into 4 areas of ways that we're managing this. So the first is around doing a lot of work on public dialogue and engagement. And we were really fortuitous to actually do a big piece of public dialogue at the very beginning of this programme, which is partly what led to the funding we then got, which really showed that there's an appetite in the UK for this and parents are actually really supportive and understand the benefits. There was some red lines in that dialogue, which have been really important in shaping some of our thinking. And so beyond that, we're planning other pieces of dialogue work where we're looking around some of the consent and how we approach that and how different communities think about it. It's thinking about some of the broader research aims of the programme and how parents feel about data linkage, what types of data. And so those are all pieces of work that are ongoing at the moment. We also put in place a lot of structures. So we have existing structures in Genomics England where we often have parent and patient representation through things like an existing ethics advisory group. And as Rich mentioned, we set up the steering group and we also have working groups and we make sure we always have parents and patient voices on those. We're also doing quite a lot of co-design work more directly. So we're very lucky to have a lot of human-centered design researchers in our team, which is a completely new experience for me working with that skill set and quite eye-opening to see how they approach things. And they've done a lot of work, both in terms of things like ethnographic research with parents, also doing work, literally co-designing what the leaflets will look like, what the logo should look like and brochures. And it's really interesting seeing what parents' takes are and what they want to see and how they want that information to be given to them. And it's really helped us define our thinking around what our recruitment strategy should be. And then finally, ethics engagement. So, we all know this is complex and there's lots of ethical issues. So we've done a combination of different things. So we actually have an active ethics working group where we deliberate a lot of the issues and thinking about how do we do consent, what are the risks of the consent process, and really thinking through and deliberating kind of the ways we might approach these things. We've also done some research from an ethical point of view, so understanding what literature's out there, and a lot of this we'll be publishing on our website in due course. And there are things in place that we're putting, such as standing public groups for us to go to on some of our ethical issues, and also doing some dedicated workshops with ethical stakeholders. And these have all been important pieces of work that have really helped shape our thinking. So in some ways, we're moving quite slowly as a programme, but what we're trying to really lay is the right foundations that when we take this out, this is something that we know will work and that people will be supportive and get behind. So just to give us an example of how this works in practice, one of the areas that we did quite a lot of this co-design approach was actually the conditions that we're going to look for. So we set up a working group initially with a range of expertise, both clinical, scientific, but also ethical and patient-facing. And they took a kind of Delphi-style approach to really think about what the principles, the conditions we might include should be, really building on some of the Wilson and Younger criteria, but thinking about what's relevant for this type of programme. We then did a lot of deliberative workshops with individuals, so parents, patients, people from healthcare professionals, and also we had an online survey where we had 440 respondents, which I think shows you the appetite for interest in this area. What that led to is the finalisation of those principles. We're about to publish those on our website shortly, but they're really the guiding kind of lights around what conditions and what genes we're actually going to include on our list. And David at the moment has been working very hard when he's not been over here giving talks, establishing an SOP, because actually the kind of hard bit is the detail. And that's a bit where actually we develop these principles, but we now have to work out what genes we think fit those principles. Some are very straightforward, others are going to be more complex, and we're going to have to work through with the clinical community. And so our plan is to publish that in late 2002, because another important part of this as well is working with the NHS to make sure we're confident that the right treatment pathways are in place. So we're actually putting in place a group of people from the commissioning side for us to work with. So we'll take our proposed lists of conditions and genes, and they'll be able to validate that we're confident that there are treatment pathways that anyone can access in England, because that's really important, is that we can make sure that all the babies can actually get treated if they have a positive result. So another area we've been sort of thinking a bit about, and I think Rich touched on this from our experience of the cancer programme, is thinking about what potential samples we might need to include. So I think DBS is obviously a really attractive proposition because we know it works with the current system, we know that it's embedded, but we also know from our experiences in the cancer programme from 100,000 genomes that when you try and utilise routine samples in the NHS with the level of variation that happens across different areas, it doesn't necessarily mean you get a sample that will work well with whole genome sequencing. And so from that, we decided to do some early feasibility work to really understand kind of what these different sample types could be and how they would work. And we did some initial work with adult volunteers in Genomics England, actually, who kindly allowed us to prick them a few times. And that then led to us to make some decisions that we then took forward into a second study, which is kicking off at the moment, which is a baby and mum sample study. So in this, we're basically recruiting 400 babies and mothers specifically just to take samples to look at the quality of them. So we won't be returning any results. We're purely doing it to understand sample quality. We're doing it across 4 hospital settings and 1 community setting, because we're taking the samples both on day 0 and day 5. And we're looking at cord blood, saliva samples, heel prick, dry blood spots, and heel prick into a capillary tube. So that effectively will give us an answer probably early next year to really understand how well we can consistently get good quality samples and which the best option is going to be. And the reality is, I suspect there'll probably be challenges with all of them, and it's picking the best one that will work for the programme. I'm going to hand over to Rich at this point.
Thank you. So this is just to sort of really frame this in terms of our thinking about where we will go as a programme in terms of evaluation, because our role here as Genomics England, working with the NHS, is to carry out a programme that develops evidence that other people within the UK and other people elsewhere in the world can look at and make decisions on whether this is something that should be adopted, when that time might be, and how and for what purposes. And that's one of the things that's been really enjoyable being here in Boston this week, and the conversations we've been having with the other groups is really thinking and hearing about how other people are evaluating programs, both because we can learn a lot from each other, and there's also a real advantage to us aligning where that makes sense, because this is an international endeavour. You know, we're lucky to be funded for what is quite a sizable program, and 100,000 babies with many conditions, with rare disease, is actually still quite a small number. So this is about sort of building the foundations for what we hope will, you know, look across the clinical utility, the cost effectiveness, but also the understanding of the impact on the health service, what the preferences are, what the views are of families and the wider public about this, because there are some really big questions here, particularly if we're thinking about sort of longer term storage of data on a substantial majority of babies. So we're sort of setting up that framework at the moment, and I think this is both about setting up a framework for the programme itself, the programme which will start recruiting next year. that will recruit over a 2-year period and then begin to give feed out, from the first year after recruitment. But what we also know is that what we want is data that's coming in quite early to give us an early view on how this is playing out. But this is not a sort of 2-year program. It's not a 3-year program. It's a lifetime program, because we need to keep on learning as we go, recognizing that the decisions that people make in the 2020s will need to be iterated, and we see that as a challenge overall in medicine, and particularly in newborn screening, as we've heard over the last couple of days. So what we're really keen to do is set those foundations and think how together, collectively, not just within our program, but in programs internationally, we can get the right evidence out there so good decisions are made, and they're made swiftly. So I hope you've had a sense of our program. We've really enjoyed talking to people about it today. We'd be really excited to be approached by people who want to hear more about it or want to partner with us, particularly thinking about industry partners as well. The success of the future of this is for us to construct an ecosystem that really works, so that we can be on the front foot with thinking about new technologies in terms of testing, but also new approaches in terms of therapies as well. Creating a system that allows us to do that knows that the knowledge of 2022 is better than the knowledge of 2012, but is not anywhere near good enough for the babies who are born. So thank you very much.